Nadu and Telangana also. Thanks for my faculty and my postgraduates. I am my all the people making the good, big a gift class for them. Not even one patient has got a delayed or maybe got a soreness of the institute. They're sitting the long time, include night 8 o'clock, night 9 o'clock also. Our radiology department working almost about morning 8 o'clock to night 10 o'clock, doing about 40 to 50 MRI scans and 20 to 30 CT scans and about almost 160 ultrasounds and lot of X-rays. Like a surgery department, and throughout the day, almost morning 8 o'clock to night 10 o'clock, our anesthesia department and the surgery department, orthopedics, all the people, per day they are operating more than 40 cases. Is a record break. Is a record break. Including our cancer hospital and including our Swatandra hospital, almost per day, we are treating about more than 1600 patients. It never happened. It never happened. Why I started this program? Because so many programs we made it a long time back, and so many conferences, so many camps we made it in and away from the Rajahmundry. But this time, what they made program and the overwhelming response. Once I analyzed it, what is the wrong, what is the things are going on. Last 16 years to 18 years, the Andhra Pradesh has suffered a lot by the way of the separation of the Andhra Pradesh, and we treated as a foreigners in Hyderabad. They thrown the stones. They asked them to learn ఇష్టమైన మాటలు మాట్లాడి అండ్ తిని పందికొక్కులు తింటున్నారు పందికొక్కులు పెంచుతున్నారు ఇష్టమైన మాటలు మాట్లాడారు. Still they made a patience. They made a patience. Again after separation, again the visionary leader has come. You want to make the state in a indifferent way, make a different way, where overwhelming enthusiasm made it. That's why, and they made all footsteps and also foundation. But luckily, unluckily, next people do to follow, and they not follow their own way. They did it, and some mishap happened. Now he came to again back to getting the construction is a very easy. Making the reconstruction very difficult. Like a follow-on project, lot of issues are going on making the reconstruction. Like that, the people are suffered a lot in Andhra Pradesh, either financially or any other thing. That's why the poor, the middle class become a poor, the poor become a below poverty line. That's why the overwhelming response is coming. I think this month also we're continuing the same program, and including today, because I started my mother's name GSL, I made a today the Amma Bhojanam Pathakam. This nominally we charging only 10 rupees, but the overall cost going to be about 40 rupees. 30 rupees we are making from our institute to make the subsidized food. ఎందుకంటే అన్నం పెట్టినప్పుడు అన్నం తినాలి. అన్నం తినలేదు ఆ రోజు దొరకదు. ఎందుకంటే ఒక ఎగ్జాంపుల్ చెప్తాను. ఒక ఇద్దరు గెస్ట్లు వచ్చారు నాకు అబౌట్ అరౌండ్ 1 year బ్యాక్. 1 year బ్యాక్ వచ్చిన తర్వాత నేను యూజువల్గా నా రూమ్కి వచ్చినప్పుడు ఎవరినైనా సరే అండ్ ప్లీజ్ లంచ్కి రండి, లంచ్ తినండి అని చెప్తాను. చాలామంది తింటారు. అతనేమో కొంచెం మొహమాట పడతాను. నేను ఇవాళ అంటే మాకు ఇంటికి వెళ్ళిపోవాలి భోజనం అంటే నేను చెప్పాను. ఎప్పుడు ఎవరైనా సరే ఇంట్లో భోజనం పెడతాను వస్తే భోజనం చేయక మానకు. ఆ రోజు నీకు లేదా భోజనం దొరకదని చెప్పాను. అండ్ నా మాటిని భోజనం చేస్తున్నాడు. భోజనం చేస్తుండగా immediately he got a call after in middle of the meals. He thought that his uncle is died. రాజమండ్రి నిజంగా ఇతన్ని ఆంధ్రవేలు వెళ్తే అంకుల్ డెత్ అయినప్పుడు వెళ్తే ఆ రోజు భోజనం దొరకపోను. అందువల్ల నా రిక్వెస్ట్ ఏంటంటే ఎక్కడికి వెళ్ళినా సరే మీకు అన్నం పెడతానంటే అన్నం వద్దని చెప్పొద్దు. మంచి డబ్బులు ఇస్తా అంటే డబ్బులు వద్దని చెప్పొద్దు. అందువల్ల మంచి పని సమాధానం చేయండి. అందువల్ల మన అందరి బాధ్యత ఈ నెక్స్ట్ 5 years కానీ 10 years కానీ మనం మన పనులు మనం చేసుకుంటా మన స్టేట్కి మంచి చేస్తా మనం ఎంతవరకు చేయాలనేది గవర్నమెంట్ ఏదో చేస్తే వాళ్ళు ఇస్తారని కాకుండా మన సమాజం మనకి మన భర్త ఇచ్చింది మన పేరెంట్స్, మన సమాజం మనకేమో విద్య నేర్పింది, మన సమాజం మన నాగరికత నేర్పింది, మనం ఎలాగ చేయాలో కూడా మన సమాజం నేర్పింది. మన సమాజానికి ఏమి ఇచ్చే మోస్ట్ ఇంపార్టెంట్ తప్ప సమాజం నాకు ఇచ్చింది అనుకో మాత్రం మన పుట్టగతులు ఉండవు. అట్లీస్ట్ దట్ థింగ్ యూ హ్యావ్ టు డూ ఇట్. ఐ రిక్వెస్ట్ ఆల్ ది పీపుల్, and this is make a things, we will make a role model of the GSL medical college for the not only state, for the country also. And COVID, we did it. In the COVID, almost about 10,000 patients were treated. And at the time, the China is proudly told that 1 week we created about 1,000 beds. At that time, I got a thought. We got 16 medical colleges in the state. Why can't 16,000 medical beds are there? Why can't you do it? Immediately, I asked the last government. Immediately, they agreed. And overnight, 16,000 beds are given by the all private medical colleges. First time in the country, first time in the world. That's why the first wave itself almost nil mortality, more, less mortality, and also more comfortability. Once the second phase, a lot of issues has come, oxygen necessity, oxygen scarcity, drug scarcity, a lot of deaths happen, and private hospitals are making a different role. That's why that's the main problem. That's why on that day we saved a lot of patients. I bow my head to all the faculty, all the nurses, all the paramedical people. What the best work they did it also. We lost about two patients, two our faculty. One is anesthesia, and one is our one of the faculty member in the paramedical person, and one is the staff. Three people are died, and also one person, two person got the compensation from the government, and luckily, and this thing, and you make a record, you'll make a records forever for GSL Medical College if they begin cooperation from you. Thank you very much.
Thank you, sir. Those words meant a lot. We now would like to call upon Yarlagadda Lakshmi Prasad Garu onto the dais and speak a few words.
He was the chairman of AP Hindi Academy Professor in Hindi at Andhra University, Visakhapatnam, and is a former Rajya Sabha member from Andhra Pradesh.
జాతీయ వైద్యుల దినోత్సవం రోజున ఇక్కడ ఈ కార్యక్రమంలో పాల్గొని మీ అందరికీ ఒక శుభాకాంక్షలు తెలియజేసే అవకాశంతో పాటు మనందరికీ జన్మస్థలం అంటే మనం ఎక్కడ పుట్టామో చెప్తారు. ఈ GSL హాస్పిటల్ నాకు మరో జన్మస్థలం. ఒక 3 సంవత్సరాల క్రితం పార్కిన్సన్ వ్యాధి ముదిరిపోయి 2.5 మాసాల పాటు ఏమి జరుగుతుందో నాకు తెలియకుండా ఉన్నప్పుడు నా భార్య భాస్కర్ గారికి ఫోన్ చేసి ఇది పరిస్థితి అంటే నువ్వేం చేయొద్దు ఇక్కడ తీసుకురమ్మన్నారు. 2.5 నెలల పాటు ఒక టీమ్ ఆఫ్ డాక్టర్స్ని పెట్టి నాకు పునర్జన్మ ఇచ్చారు. దాన్ని ఏమన్నారంటే మెడికల్ మిరకిల్ అన్నారు అందరూ. ఆ మిరకిల్ని చేసి చూపించిన వారు భాస్కరరావు గారు. GSL మెడికల్ కాలేజీ నాకు మొట్టమొదటి ఇటుక నుంచి తెలుసు. నాకు భాస్కరరావు గారు, వారి సోదరు కృష్ణ గారు, వీరిద్దరి కంటే కూడా వాళ్ళ నాన్నగారు కూడా ఎంతో ప్రజాసేవ తత్వంతో ఈ కార్యక్రమాలని చేపట్టేదాని యొక్క స్ఫూర్తిని వీరికి ఇచ్చారు. అయితే డాక్టర్ గారు ఒక విషయం చెప్పారు. ఎవరన్నా అన్నం పెడతాను అంటే వద్దని అన్నారు మిమ్మల్ని. నేనేం చెప్తానంటే ఎవరన్నా మీ దగ్గరికి వచ్చి ఆకలి అంటే మాత్రం తప్పనిసరిగా భోజనం పెట్టండి, మీరు మానేసైనా సరే. ఇంకొక విషయం ఏమిటంటే మన సమాజంలో చూస్తూ ఉంటే చాలామంది వైద్యులు చాలా వైద్య వృత్తితో పాటు లయన్స్ క్లబ్, రోటరీ క్లబ్బుల ద్వారా ప్రజాసేవా కార్యక్రమాలకు ఉంటారు. నేనేం కోరుతున్నానంటే లయన్స్ క్లబ్, రోటరీ క్లబ్లో చేరండి. అట్లే కాకుండా కళలు, సాహిత్యము అనేటువంటి విషయాల్లో ఏమన్నా కొంచెం మీరు కూడా ఆసక్తిని కనబెట్టి మీరు ఎక్కడ ప్రాక్టీస్ పెడతారో, ఎక్కడ ఉద్యోగం చేస్తారో ఆ నగరాల్లో మీరు ఈ కళలు, సాహిత్యం సంబంధించిన వాళ్ళు కూడా మీరు చేయొద్దని కోరుకుంటూ మరొక్కసారి మీ అందరికీ కృతజ్ఞతలు తెలియజేసుకుంటూ సెలవు తీసుకుంటున్నాను. జై హింద్.
థ్యాంక్ యూ సార్, మీ విలువైన సమయాన్ని మాకు కేటాయించినందుకు.
Now we'd like to invite our chief guest, Dr. Dattatreya Nori Garu, FACR, FACRO, FASTR, onto the dais.
నమస్కారం అందరికీ అండి. ఫస్ట్ హ్యాపీ డాక్టర్స్ డే ఫర్ ఆల్ డాక్టర్స్ అండ్ వుడ్ బి డాక్టర్స్ టు. నేను ఇక్కడికి వచ్చి 4-5 గంటలైంది. డాక్టర్ భాస్కర్ గారితో నేను రాత్రి నుంచి కడుపుతూ వచ్చాను. హైదరాబాద్ నుంచి వచ్చాం ఇద్దరం, భాస్కర్ రావు గారు. ఇప్పుడు ఆయన గురించి చెప్పాలి ముందు అంటే నేను ఎక్కడ మొదలెట్టాలి, ఎక్కడ ఏం చేయాలి. నేను ఇటువంటి ఫంక్షన్కి వెళ్ళినప్పుడు మెయిన్ హోస్ట్ దగ్గర చాలా నేర్చుకుంటూ ఉంటాను. యాజ్ ఎ డాక్టర్ ఆయన హ్యూమిలిటీ, ఆయన ప్యాషన్ టు డూ మోర్ ఇన్నోవేటివ్ థింగ్స్ and compassion towards patients. How can we improve their status, give them best possible treatment with affordable costs in a beautiful environment like this? So I'm extremely impressed, sir, Dr. Bhaskar Rao. I'm extremely impressed. And I will definitely learn so many things from you. And waking up at 5 o'clock and doing yoga, I will start doing that when I go back to America. Thank you. Today, what I'm going to do is give you a little background of where we are in cancer treatment. What have we learned in the last 25, 30 years? How did it change the outcome of cancers? What are the new things coming in the horizon? So please be patient with me. This is mainly to inspire new generation of postgraduates. This is how I got inspired when I was sitting there like you in Karnool Medical College and Osmania University. So I would like to take you through a journey of medical innovations in oncology, in cancer. First slide, you can join it. Okay, next one. Every forward this. The cancer. Okay. Okay. Backward, 1 second, please bear with me. Okay. ఓకే, 4 హెడ్డింగ్స్లో చెప్తానండి. తెలుగులో కొన్ని చెప్తాను, కాంప్లికేటెడ్ స్లైడ్స్ సింప్లిఫై చేసి చెప్తాను. మనం ఎంతోమంది విఐపి గెస్ట్ ఉన్నారు, నాన్ మెడికల్, సో వాళ్ళందరికీ కూడా కలిపి చెప్తాను. వాట్ వీ విల్ గో త్రూ ఈస్ ఇవాల్వింగ్ పారాడైమ్స్, న్యూ డిస్కవరీస్, అడ్వాన్సెస్ ఇన్ క్లినికల్ ఆంకాలజీ అండ్ artificial intelligence. Where are we with that? Advances in oncology, predictors of outcome for those postgraduates, primary predictors. When you do a biopsy, what we used to depend on, size of the tumor, ploidy of the tumor, is it well differentiated, poorly differentiated? That is history now. We know more than that now. That is, next secondary predictors are tumor markers, ploidy and receptors. Now tertiary markers are gene expression. What is the mutational landscape of that particular cancer? We have come a long way to understanding that. EGFR receptor mutations, molecular and proteomic staging and profiling. So I will take you to the last slide to tell you what advances pointed out like that. This appears to be complicated slide. I will explain to you even for non-clinicals, non-doctors here. That in the past many decades, we thought, isn't a pointer? Is one just okay. The center, that blue zone, DNA, we know cells are multiplying because of uncontrolled DNA production. And we were giving radiation, chemotherapy, surgery, everything, trying to knock it down and completely eliminate the cancer. But we didn't know until 33 decades ago, why is the DNA getting stimulated? Who is giving the signal to the DNA to multiply? Then we realized through our research, look at the cell membrane. Each cell has a membrane. Babu, ఇది పని చేయట్లేదా? Useless. Each cell has a nucleus in the center and a cell membrane.
Sir, pointer is not there, sir. Display.
Huh?
Only slide, sir. No pointer.
ఇక్కడ దీనికి కనిపించచ్చు కదా?
లేదు సార్.
లేదా? సరే అయితే ఓకే. Each cell has a nucleus and a cell membrane. I will try to explain with my fingers. It is not working. So, we have believed for a very long time that multiplication is happening in the center, but we didn't know that. But later on, about 2.5, 3 decades ago, we realized the signal for the DNA to multiply is coming from the cell membrane. Cell membrane, just imagine like a wheel. The central hub is the nucleus. The periphery of the rim of the wheel, the spokes, you consider that as signals. So the cell is getting multiple signals from all around. One signal shows the cells to multiply. The other signal shows the cells go and metastasize to liver, lung, brain, everywhere. So the third signal tells the cells, develop your own blood supply. So our understanding of the path of how the mutational landscape of the cell gave us a lot of clues how to block these signals, each signal. If we block one signal, you can control the growth. If we block other signal, we can prevent the cells going to the brain, liver and lung. So each silo, whatever you call on the cell membrane, we found a drug for each item of the aberration around the cell. The next slide shows, I'm sure you have. So these signals can be coming from the peripheral zone, that is the rim of the wheel, and from outside of the rim of the wheel also. So far, I hope made clear. Now what we did, for each signal coming from the periphery, we found a drug, how to block that signal. We found a drug. So these signals, most of the signals can be blocked by the drugs we develop to prevent the cells from multiplying, prevent the cells from metastasizing, prevent the cells from developing their own blood supply. So how did that translate into advantage to the patients? Targeted therapies. Now we target if there is an aberration in a cancer cell, of a particular gene change, we can correct that by pills, by injections, mostly by oral pills. Targets Herceptin in breast cancer, most of the oncologists know about that. With the use of that particular Herceptin blocking that one function on the cell membrane, we improve the cure rate of breast cancer by almost 40 to 50%. Another one, Avastin, in advanced lung cancer, ovary cancer, and colon cancer, we improved the survival by the blocking drug of that particular signal. And rituximab in lymphomas improved the survival in lymphomas by almost 70%. The other one is Tarceva for lung cancer. Tarceva is extremely useful drug in even metastatic lung cancer. I have treated so many patients from India. Metastatic lung cancer in women, never smoked, and this drug works better even in widespread metastatic disease. They can go without any disease for 10, 15 years. Then the Gleevec, very important for everyone, all the students to know, for chronic myelogenous leukemia, by taking this tyrosine kinase inhibitor, Gleevec, you can cure chronic myeloid leukemia by just taking one pill a day for any number of for a few months. The last one is for multiple myeloma. So we have made significant breakthroughs in understanding the signals and finding a drug for blocking those. I'm sure you are with me so far. If you are a very intuitive, curious individual, you will ask me, sir, each drug is blocking only one signal. But cancer is really a nasty thing. It has multiple areas. So how do you control the multiple signals coming from the cancer cell? That is immunotherapy. Immunotherapy blocks all the signals. So that is, immunotherapy is a game changer now in every cancer, and we are spending close to $450 billion in developing research in immunotherapy. It is available here, it is available in India, in all the hospitals. How does that work? This is a complicated slide. I don't expect you to read that. Remember, as the cancer develops in the body, it produces two nasty substances. One is called, you see here that one, CTLA4. It's a nasty substance developed by cancer as it grows in the body. The next one is PD1. There are two nasty substances. One is the previous one, PD1, and then the other one is CTL4. So far you are with me. So how do we address this issue? What these two antigens, what we call are nasty toxic substances produced by cancer, are doing is they are destroying our command and control center in the body of the immunity, immunological control center in the body. So your immunity is down and the cancer grows. So what we did is found the drugs to block these two antigens, to block these two toxic substances. I will share with you this next slide. These two. I mentioned to you there are two nasty substances, CTLA4 and PDL1. The first gentleman discovered this agent, CTL1. The second gentleman discovered the second agent, PDL1. Both of them got a Nobel Prize because this is a major breakthrough in immunotherapy of cancer. Why? I will show you the example, one from New York, one from Japan. I will show you an example of how beautifully, how great these drugs work. Immunomodulators, they are called immunomodulators, are releasing drugs, blocked by cancer. It is releases the blocked by check mark produced by cancer. I don't have the pointer, but take it from me. The slide on the left side of this shows a metastatic colon cancer. I'm sure our doctors are following. Dr. Bhaskar, this patient has metastatic cancer, metastasis to the lung, liver, and a presacral space. You can see on this part of the slide, which I cannot show you with the pointer. The other side, go to the other side, sir. Yeah. The liver disease, look at the hilar disease, next one, bring it down, come down all the way. Next, yeah. The presacral mass disappeared with immunotherapy. After immunotherapy, this patient is 12 years without evidence of cancer after immunotherapy, who came with metastatic colon cancer, metastasized to every organ in the body. The next example I'll show you is this gentleman. I'm sure you can recognize him, or past president of the US. He developed cancer which has metastasized to brain, liver, lung, and bone. And we treated him with the same immunotherapy and a little bit radiation to the liver, and he is alive. He's in a nursing home because he's 101 year now, but free of cancer. Completely all the metastatic sites have disappeared with immunomodulation. These are called immunomodulation drugs. This is an important example. Please follow through me. If you have a patient group, 100 patients, breast cancer, all of them have a small lump in the breast, small lump T1 lesion, no nodes, no metastasis. You give standard of care treatment, lumpectomy, radiation, or mastectomy. It's a very adequate treatment. Everybody should be surviving, but only 70 to 80% are surviving. 20% we are not able to control the disease. Why is that? We didn't know that before. So if you take 100 patients, if you analyze them, not every cancer is same in these individuals, even though they are appearing as a small lumps in the breast, T1 lesions. So here if you see the different, when you do molecular profiling of the cancers in these individuals, you will come to know, even though everything looks the same, the molecular profiling, how they formed as a cancer in each individual is different. So that dictates how the treatment works in this patient. So what we need, a treatment Take the central group, the patient composite group is the central group there. The upper corner green, drug, if you use chemotherapy on any particular cancer, the drug is toxic and beneficial. The other side is the toxic, is the drug is toxic, not beneficial. The bottom is drug not toxic, not beneficial. The last one, all blue, is drug not toxic and beneficial. So if you take 100 patients and apply all the treatment, non-treatment, only a small portion of them are benefited, the remaining are not benefited. Because we are giving the same treatment even though molecular profile of this cancer is different in different individuals. That we come to know now. Now we are applying customized precision treatment based on their molecular profiling of individual patient, individual cancer. So now we move to advances in clinical oncology, which is much easier to understand. You have seen explosion of all radiation technologies, most advanced technologies. You have, we opened today the Electra new machine, which has all the gadgets that you need for stereotactic body radiation, stereotactic radiation also. So this treatment is available here, stereotactic SPRT, that with a few fractions of radiation, you can cure lung cancer, small lesions, small cancers. This is available here in your hospital. And this is an example of a stereotactic radiotherapy treatment. Patient treated for the lesion there, and you don't see that after 10 years. This, the advantage here is a highly precise treatment, so you don't see any other negative effects on the rest of the lung or rest of the body. The new advance in technology is a proton beam, available in few places in the country and available in most of the centers in America. The advantage of the proton beam is the beam of radiation is a finite radiation. It will go to certain depth and stop. So you don't see any problems of the radiation effects on the rest of the body, only the tumor is treated. This is the technology that is coming also in India. We have these two machines in America in my department. Just it's an animation here to show how precisely you can hit the target when you see. This is what is called adaptive radiotherapy. We know when you treat prostate or pancreas or any lesion, it is not the same lesion you treat every day because it moves. The body moves with respiration. So this treatment, if the target is outside the beam, it will stop, automatically stops, until the target comes within the beam, within your prescription. This is a pancreatic lesion. These are, even though they are cartoons, they are real patients treated, hundreds of them treated in my hospital. This is day one, look at the location of the pancreas, and the day two, location has moved because of respiration, but the beam will not go through unless it comes into the field of radiation. So this is highly precise radiation treatments available in the country, and they will be coming here also. I will not show you. Okay. Now the next one is the breast cancer. Breast cancer, we all know that mastectomy is one option, or lumpectomy plus radiation is another option. What our investigators at Sloan Kettering and New York Presbyterian did is, especially for people like, for patients like in this country, they cannot come every day for weeks, by 5 weeks, 6 weeks, 7 weeks. So what we did is we simplified the treatment to, I'll come back, from 6 weeks to 3 weeks to 1 week to 1 day. Intraoperatively, one treatment will give the same result as 6 weeks, 7 weeks of treatment. The advantage here is you are simplifying the treatment, the outcome is not compromised, and it's very patient friendly because they don't have to travel to your department multiple times. This is, I'll give you a short story here. This is called a remote afterloader, which you have here. I was giving a brief introduction today during rounds. When I was in Usmania University, long time ago, doing my post-graduation, I was asked to go to cancer hospital to treat a cervical patient, cervix patient. I went to the hospital and the doctor, my professor said, we have radium in this patient, you go and give penicillin injection prophylactic. I said, I have no problem. But next day he asked me to go to another room where there are 10 patients placed in one room and asked me to do the penicillin injection. The radiation exposure to the doctor, to the nurse, and to the patient herself is an incredible amount of radiation, unnecessary radiation. So I refused to do that. Then the thought came to my mind, this kind of primitive treatments have to change. So the first thing I did in mid-70s when I went to America, to Sloan Kettering, I designed this machine, what you see on the robotic machine, where the radiation source is a miniaturized source. It is attached to a micro cable that moves by microprocessor, gives radiation and comes back into the safe. So this is called a remote afterloader. We designed it. Now multiple companies are producing that. You have one here. I am very proud to share with you that there is not even single hospital in the world that did not have this machine, which has simplified the radiation delivery, is safe to deliver radiation and no exposure to anybody in the treatment team. So this is a major breakthrough. So that's what we apply in breast cancer also. This is here for surgical oncologists. This is not only useful in breast cancer, in gynecological cancer, intraoperative radiation too. If you find a tumor unresectable or mostly resected but leave behind few cells, you place the catheters, the next day or two you connect them to the machine, it gives like a perioperative radiation to that segment. They don't have to come back for post-op radiation. Please utilize them adequately. I will show you a few examples of that. This is the machine I was talking about. Now I'll give you the surgical examples, especially for Varun and his team. This is the patient. I don't have the upper lobe, right upper lobe. You have that big mass, and then look at the CT scan. The vertebral body is destroyed, the ribs are destroyed, and how do you treat them? This is unresectable by definition, and the patient has only 6 months to live with this kind of problem. So we resected the lesion, we reconstructed the ribs. We look at those catheters, Varun, those catheters are placed right in the surgical bed. And then we gave perioperative radiation with the remote afterloader. This patient survived 10 years after that in spite of positive margin. These things can happen. This is mainly for surgical oncologists. The next one is you see the tumor on the left side here, left apical lung cancer, and we resected the tumor. The white portion is the tumor, the rest of them is a normal lung. We resected that, but margins are positive in this case. If we don't treat positive margins, this guy will have recurrence and have a miserable time with post-operative and in the next 6 months' time with excruciating pain and all that. So we design new techniques as we need at our hospital. One technique I designed is we have worked developing micro pellets, micro radiation pellets. We can place them in a vicryl mesh and using gel foam and place this vicryl mesh into the surgical bed. And that will make the positive margin into negative margin. And this is very safe to work with. These are available, the pellets are available in India. Some of the Tata Memorial is doing it. Some of the centers are doing it after we train them. This example here, this is the way we do that. The entire procedure takes 10 minutes intraoperatively. And you place that plaque right in the surgical defect. Then it turns a positive margin to a negative margin. Why I am saying this example is our president, Neelam Sanjeev Reddy. You have seen him on the slide in the beginning. He came to me from All India Institute. They found a small lump in the lung. They transferred him to Sloan Kettering. We wanted to do resection of the lung, lobe. Varun, we wanted to do resection of the lobe, but he has a severe COPD, lung compromise because he was a smoker. So even though we can do comfortably lobectomy, we could not do because of he would not tolerate. So we just removed the lump only in the lung and treated him with intraoperative, that plaque therapy I mentioned to you, which takes only 10 minutes. He survived 18 years after that, and then died of unrelated non-cancerous causes. So he was so extremely pleased with what we did at Sloan Kettering, and I'm gratified that everything worked for him well. This is, I don't see Dr. Mrs. Bhaskar Rao here. She here, gynecology. This patient, this patient, if you see that spot where the laser was pointing out, this is a 50-year-old female. I get patients from all over the world. This patient came to me from Israel. After hysterectomy was done, she developed a parametrial recurrence. You see where the spot is there, parametrial recurrence, and was asked to take morphine and things will be over in 6 months. Usually the pattern is they go from other countries first to London, then they come to us. In the London, the treatments are not that aggressive, unfortunately. She came to me, and then we designed a new treatment for her, individual treatment with a different kind of radiation, and we treated her. The tumor has disappeared, and she has been coming for follow-up every year. Last year, she sent me New Year greeting cards. She sent me a New Year greeting card. In the card, she said, Dr. Nori, we just celebrated 55 years of wedding anniversary, and 30 years of that is given by you. She is 30 years post-treatment. So I am particularly, my practice at Sloan Kettering and New York Presbyterian is taking these challenging cases where everybody says no. I will try to work with them. We have a big team. Teamwork is essential in oncology. So develop a team. These things also can be done here if you develop a team. I will not go into more details, only a few couple of slides. AI, artificial intelligence. If you subject any X-ray, CAT scan or MRI to artificial intelligence review, it can pick up the lesion. For example, a patient has breast cancer. Go back and feed into the computer 3, 4, 5 years back mammograms of that patient. It will show you the patient has breast cancer started 4 years ago, and this is the spot. This is the spot you missed. So this artificial intelligence technology is extremely useful to detect the cancer significantly much earlier than you expect with conventional imaging studies. So it is going to revolutionize early detection, breast cancer, lung cancer, uterine cancer, every cancer. Artificial intelligence, there are other bad things about that. In medicine, AI has all good things for us, luckily. This is another, next example this is the breast example. This is a prostate cancer also. Usually MRI, transrectal MRI or any MRI study, it shows few status and it will not give you good information. If you subject the scans to AI's review, it will pick up where the lesion is. And you can see that next slide, I'll show you. This picked up the lesion is here which we missed. This is AI review, after AI review. So I will conclude with a summary slide that the 5 pillars of cancer treatment now, surgery, you have seen that cytotoxic chemotherapy, radiotherapy, precision therapy, I told you that. The precision therapy is that wheel, blocking drugs. The next one is immunotherapy, is going to stay here. So ask your patient or ask patients if there are anybody here, ask your doctors, am I a candidate for immunotherapy? So these NGS next generation sequencing studies are available here. I'm sure it is foundation one studies are available here. By that you can pick up, I'll give you one example of that. There is a CEO of a big major hospital in Hyderabad who came to me with all metastatic disease. Lung went to everywhere. I mentioned that to you, the ALK positive. ALK positive, he is ALK positive. That particular gene's fusion was abnormal in that case. We found out through the next generation sequencing study. And then we put him on oral medication only. His widespread metastatic disease disappeared, and he is over 4 years now without any disease, doing very well. This is the kind of most gratifying results you can get, not in every individual, but only if you do these advanced molecular testing, you will be able to pick it up. Thank you very much for your time.
Thank you, sir, for all the knowledge you have shared here. Now, let's move on to the main part of the event. Now, let us invite our chief guest, Dr. Dattatreyu Nori Garu, onto the stage for felicitation.
It's a proud moment for me to read out the names of people who have contributed to the growth of this institution. If somebody asks me why GSL, what is the greatness of GSL? It is not because we have a library which is of first of its kind in any medical college. It's not because we have a simulation lab which goes on growing. It's not because we have a separate cadaveric lab and a beautiful anatomy dissection theater. It is not because our hospital is full of equipment which nobody has. It is not because we are housed in a campus which is green, but it is because we have a management which is led by Dr. Bhaskar Rao, who always think of college as first. It is it is 6 years since I have been here, and every year, every moment there is something new which is inaugurated in this college, and it is still going on. You can see the hospital which is transforming at a very fast pace. Before I start, I would like to read out the message given to me by my mentor in this college, Brigadier Y.V. Sharma. He sent me this early in the morning. My dear General, thank you for inviting me to join you in Doctor's Day celebrations. In my 15 years of unblemished service at GSL in various positions, I never missed participating. It was a joy to be associated with this institution. I would have loved to join you all to celebrate Doctor's Day, which also happens to be the GSL Medical College Foundation Day, but for my indisposition. Nonetheless, my heart and soul are there with you all in these celebrations. Please convey my best wishes to all staff, students, and the management of GSL Healthcare Institutions. Wishing you the best on this glorious oration. Regards, Y.V. Sharma. The list which I am starting has got no alphabetical order. It so happens that the staff list that we have in the principal's office starts with the Department of Anatomy and ends with the youngest department, which is the Department of Medical Gastroenterology. So please don't be carried that some names are coming first, some are coming behind, because it's based on that book. So first, there are many people who are not here, painfully not here, but still it's my duty to read out their names. I start with Dr. A. Rammohan Rao, who was the first principal of the college. Brigadier Y.V. Sharma, the dean, he was here in this college for almost 18 years. Dr. Srimati K. Venkat Ratnam, Department of Anatomy. General Y.S. Sharma, Medical Oncology. Dr. NVSL Narsimham, Forensic Medicine. Dr. Veeranjanelu, ENT. Dr. Padmasri Devi is here, ma'am. Please come over to the stage. Somebody please escort Dr. Padmasri Devi. I request some postgraduates over there. While Dr. Padmasri is coming, I would request Dr. Lalita Devi, Department of Pharmacology. These people have retired, but on my request they have come. So I'm so much obliged to them. Dr. V. Sarojini from the Department of Gynecology. While she's walking up, I would like to read the other names also. Dr. K. Srinivas Rao, my teacher and professor of ophthalmology. Dr. Nalli Mohan Rao, general surgery. Dr. M. Mishra, pathology. Dr. Kasur Bharatalakshmi, gynecology. This is Dr. Padmasri Devi. Dr. Sarojini Devi, Department of Gynecology. Lalita Devi, Department of Pharmacology. May I request Dr. Hemlata Devi from my own department, Department of Ophthalmology. There are the other retired people, Dr. Kasur Bharatalakshmi, Dr. P. Satyavati, Dr. K. Satyanamurthy, Pharmacology, Dr. MBR Sarma, Anatomy, Dr. Raghavrao, Microbiology, Dr. V. Subbireddy, Pharmacology, Dr. Y. Jagannath Rao, Forensic Medicine, Dr. GSP Prasad, Pathology, Dr. E. Babji, Pediatrics, who I am told is now no more, Dr. Kotni Shivshankar, Radiotherapy. Dr. Prasad Chaudhary from Dermatology, Dr. Bhavani Prasad from General Medicine, Dr. K. Ramchandra Raju from General Medicine. These are the people who are retired. I will now read out the list of people, faculty who have served for 20 years in this medical college. It's may I start with Dr. Hiraman Singh, HOD Microbiology. Dr. Hiraman, you can get onto the steps. Dr. Jayachandra, may I request Dr. S.K. Mishra, Community Medicine. Dr. Srihar Babu, General Medicine, sir, please. Dr. S. Srinivas, Neurology and General Medicine, sir, this side, sir. Dr. Srihar Babu, sir. Dr. Somnath Das, HOD Respiratory Medicine. Dr. M. Panikumar, Neurosurgery and General Surgery. Dr. Vijayalakshmi, Anesthesiology. Don't worry. Ma'am, we'll change it. It will now. It is going by. Dr. P. Brahmananda Rao garu. After Vijayalakshmi, madam. Dr. Hemabindu, madam. I'll also read out the names, many of whom are not here. Dr. G. Nageswar Rao, Pathology, Dr. TVS Sivakumar, General Medicine, Dr. Sheshadri Reddy, General Medicine, Dr. A. Rajshekar, General Medicine, Dr. C. Radhamani, General Medicine, Dr. N. Ravikiran, General Medicine, Dr. Gudir Srinivasalu, Respiratory Medicine, Dr. G. Sriram, Pediatrics. I am told Dr. T.V. Balakrishna is here, General Surgery. Dr. T.V. Balakrishna. Somebody has seen him. Dr. Bomman Krishna Kumar. Dr. Bomman Krishna Kumar. Dr. G. Sriram Pediatrics. Sir. Dr. Bomman Krishna Kumar, General Surgery. Dr. P. Vijaya, Ophthalmology. Dr. P. Praveen Kumar Reddy, ENT. Dr. Mrs. Kasimbi, Gynecology. Dr. A. Venu Madhavi, Gynecology. Dr. Shinoy, Anesthesiology. Dr. P. Srinivas Reddy, Anesthesia. Dr. S. V. Ramana, Anesthesia. Dr. S. Ganeswar Rao, Anesthesia. Dr. S. Venkat Subbarayal Reddy, Anesthesia. All these are people who have served for 20 years in this college. We now come to people who have served from 10 to 20 years. Dr. N. Surikamari, Anatomy. Followed by Dr. Vamsi, Anatomy, and Dr. Sujata, Anatomy. Dr. Srinivas, Physiology, and Dr. Mrs. Kavita Marita, Physiology. Dr. Mallikarjun Rao, Biochemistry, and Mrs. T. Durga, Biochemistry. Huh? I'll now request that a faculty from pharmacology, Dr. K. Ravi Babu, Dr. K. Nagaraju, and Mrs. P. Maheshwari. Dr. Mallikarjun Rao, Biochemistry. I'll now request Kan Satya Prakash, Dr. Manisha Mahapatra, and Dr. Mark Ruth Prasanna from the Department of Pathology. Dr. Ruth, may I request Dr. Pragati and Dr. Aruna to join the line along with Mr. Kranti Kumar. Ma'am, this side. Kranti Kumar garu. Would I request Dr. Uday Bhaskar Reddy, Forensic Medicine? Dr. Mrs. Sipra Komal Jeena, Dr. P. Jayasri, Dr. Ganapat Swami, Dr. J. Raj Sudharani, all from the Department of Community Medicine. This side, ma'am. Madam. Dr. S. V. Ramanamurthy, General Medicine is in London. Dr. Chakravarti, DJK Chakravarti, General Medicine. Dr. M. Vijay Gopal, Dr. Ramakrishnan Paramahamsa and Dr. Kalyan Chakravarti from the Department of Pediatrics. Dr. K. L. Narasimha Rao and Dr. from General Surgery. I must tell all the students that this is a very rich college, which is having so many faculty who are serving in this college for 20 years long. And that shows the richness of the college. Dr. V. Nageshwar Rao, HOD Orthopedics. Dr. Jagan Mohan, Orthopedics. Dr. K. Satish, my HOD. Just call Murli. Call him fast. ఈ సబ్బి రంజన్ నాయకు రాఘవంత నాయకు పేర్లు ఎగిరిపోయి ఏంటి అలాగా ఇంకా నేను మిస్ ఏమో చూడు. Dr. S.R. Nayak, Dr. Samir, and Dr. Raghavendra Rao. I'm sorry, Samir sir and Raghavendra sir, your names have slipped out. It's a typographical error. Please excuse me. Both these people are forefathers of this college. Dr. Mrs. Y. Annapurna, Gynae. Brigadier TVSP Murthy, Medical Superintendent, MS. Yes, please. Dr. Pramod and Dr. Anandita Mishra from the Department of Radiology. Followed by Dr. CHK V. Sirisha, Anesthesia. My HOD's wife. And Dr. Kiran Mai from Reproductive Medicine and Surgery. Could I request our PD, Srinivas Rao Garu? PD sir. Dr. N. Lakshman Kumar, Biochemistry. Dr. E. Usha Bhargavi, Pathology. Dr. V. Suresh, Medicine. Dr. A. Veerraja, Medicine. Dr. N. Ramchandra Gupta, Medicine. Dr. C.H.V. Ravikiran, Medicine. Dr. P. Ramamani, DVL. Dr. G. Ganesh Babu, Pediatrics. Dr. Akul Sachinayana Garu, Pediatrics. I had seen Dr. Sachinayana, sir. Namaskar, sir. Dr. Akul Sachinayana. Dr. K. S. Rajshekhar, General Surgery. Dr. K. Srinivaslu, General Surgery. Dr. Muchal Srinivas, General Surgery. Dr. V. Sarath Kumar, General Surgery. Dr. Bal Gangadhar Rao Garu, General Surgery. Dr. K. Ramananda Reddy, General Surgery. Dr. B. Gopal Krishna, General Surgery. Ramananda Reddy. ఆయన గోపాల్ డాక్టర్ రామానంద రెడ్డి గారు డాక్టర్ సిహెచ్కే తులసి మోహన్ రావు గారు డాక్టర్ కర్రీ శ్రీనివాస్ ఆర్థోపెడిక్స్ Dr. N.V. Narasimha Rao, Orthopedics. Dr. Supradeepta, Orthopedics. My teacher, Dr. B. Nagendra Babu, Ophthalmology. Dr. Y. Ajay Kumar, ENT. Dr. G. Anantalakshmi, Gynecology. Dr. A. Chittisudha, Gynecology. Dr. K. Chandrika, Gynecology. Dr. B. Veerana Chaudhary, Anesthesia. Dr. Y. Suresh, Anesthesia. Dr. NVP Vinay, Radiology. Dr. D. Venkatramana Rao, Radiology. Dr. P. Krishnamohan, Radiology. Dr. K. Jayasudha, Radiology. Dr. V. Ramchandra, Radiology. Dr. Muchal Raidu, Radiology. Dr. C. Sivaram Krishna, Emergency Medicine. Dr. D. Ramarao Garu, Emergency Medicine. Dr. G. Kanti Teja, Reproductive Medicine. Dr. V. Sriramlu, Medical Gastroenterology. Dr. S. Ravikant, ENT. Dr. N. Murali Krishna, General Medicine. And Dr. Kani Bhaskar Rao, General Surgery. We shall now read out the names of our non-teaching staff.
Kanchana Venkateswara Rao garu.
బొడ్డెం వి కృష్ణ సూర్య నాగేశ్వరరావు గారు.
Palivela Bhaskar Rao garu.
Dr. V. Krishna Rao wants to honor our chairman.
Been talking to myself forever. Yeah. And I wish I knew me better. Yeah. Still sitting on a shelf. I never see the sunshine. And it feels like me on a good day. On a good day. On a good day. And it feels like me on a good day.
కంచన వెంకటేశ్వరరావు గారు.
బొడ్డం వి కృష్ణ సూర్య నాగేశ్వరరావు గారు.
పలివేల భాస్కరరావు గారు.
వైఎస్ఎన్ మూర్తి గారు.
ఎం బప్పన దొర గారు.
ఎం విజయ్ భాస్కర్ రావు గారు.
ఇసుకపూడి వెంకటరావు గారు.
బయ్యే రమేష్ బాబు గారు.
సుంకర నాగేశ్వరరావు గారు.
వెల్లిచేతి శ్రీనివాస్ గారు.
గంగం కృష్ణయ్య గారు.
కె శ్రీనివాసరావు గారు.
వాసంశెట్టి శ్రీనివాసం గారు.
బొల్ల నాగేశ్వరరావు గారు.
సిహెచ్ అరవరాజు గారు. సిహెచ్ అరవరాజు గారు.
డివి సుబ్బారావు గారు.
పిల్లి ఆశ్రయ గారు.
యాడమ్మారెడ్డి వెంకటేశ్వరరావు గారు.
పి సతీష్ కుమారి గారు.
కుటుంబరాణి గారు.
కొరపాటి గంగాభవాని గారు.
కె జగమోహన్ రావు గారు.
కె జగన్మోహన్ రావు గారు. కందుకూరి సూర్య బసవరాజు గారు.
తమ్మినేడి రామకృష్ణ గారు.
సురేష్ కుమార్ పెమ్మనబోయన.
ఎల్ సూరిబాబు గారు.
మార్ని వెంకట సుబ్బారావు గారు.
గోరతి శారదాదేవి గారు.
మోర్తా ప్రసాద్ గారు.
ఆడప రాంబాబు గారు. జె రామకృష్ణ గారు.
మారిచెర్ల శ్రీనివాసరావు గారు.
మొహమ్మద్ అలీ అన్సారీ గారు.
గుత్తుల సత్యనారాయణ గారు.
వై సతీష్ బాబు గారు.
వాడపర్తి శ్రీను గారు.
కె శ్రీనివాసరావు గారు.
కందుల శ్రీనివాస్ గారు.
కె గౌరీశంకర్ రావు గారు.
టి శ్రీహరి గారు.
అలెమ్మ పి వర్గీస్ గారు.
ఎస్ సంతోషమ్మ గారు.
మొహమ్మద్ బషీరుద్దీన్ గారు.
మేడికొండ బాలబాబా వెంకటరమణ గారు.
సున్నం కామరాజు గారు.
పాలికా రామకృష్ణ గారు.
సిహెచ్వి చౌదరి గారు.
చంద్రాల వెంకన్న చౌదరి, ఫార్మసీ.
ఎన్ విజయానంద్ గారు.
జె సుజాత గారు.
This list has been compiled by the HR and the principal office. If there are any mistakes, any misses, please let me know. It's a humble request. May we now stand by for the national anthem.
But I